Next up, we have Dr. Desai, who is an assistant professor of medicine at Weill Cornell Medical College and an assistant attending physician at New York Presbyterian Hospital to discuss the recent advancements in the treatment for patients with acute myeloid leukemia. Hi, Dr. Desai. We're so happy to have you here today.
Same here. Very excited.
So, 2018 has been such a progressive year for AML treatment. What are some of the advancements that have happened just over the last couple of weeks that you can mention?
So we have obviously 3 new drug approvals in the last 2 weeks. We have venetoclax, glasdegib, and gilteritinib, all approved just in the last 2 weeks. It's been whirlwind, actually. As we know, venetoclax and glasdegib has been approved for frontline treatment of AML. Venetoclax is approved for combination with hypomethylating agents and low-dose cytarabine, and glasdegib has been approved in combination with low-dose cytarabine. Obviously, gilteritinib is now approved for FLT3 mutated AML in the relapsed setting. And these were very important trials that we've been waiting responses for a while. And it's changing the patterns of practice in AML we've not changed the practice of AML in such a long time. This is high time.
Definitely.
Yeah.
Now, going into the frontline venetoclax approval, which patients is this best suited for? And obviously, if you could also maybe talk about the venetoclax data that we're seeing here at this year's meeting.
Sure. So the venetoclax trials were done in patients who were either over 75 years of age, or they were older, 60 to 75, and were considered unfit for induction chemotherapy. So these were all the patients who were enrolled into the trial. So this is where the drug is approved for and has an indication for. And the data has been very promising, because if you look at the data that was just presented at ASH for the hypomethylating agent backbone with both Vidasa and decitabine, the responses have been approximately 70%. So if you compare it with single agent historical data for hypomethylating agents, it has ranged from between 20 to 40%. So this is substantially improving the CR rate. And I think what is actually important also is that the venetoclax seems to be a mutation agnostic drug. So some of the mutations that we consider high risk that don't show response have also shown responses. I think the data we just saw at ASH that about 60% of TP53 mutations are responding to it frontline, and over 90% of the IDH mutations. So it's nice to have a drug that is kind of mutation agnostic.
Definitely. Now, we're also seeing data from the Quantum R study looking at quizartinib in FLT3 ITD positive AML. So could you discuss these data?
So these were also long-awaited results. This was a randomized phase 3 study of over 350 patients of AML. Quizartinib was randomized to what we considered investigator choice or standard treatment. That was a mix of lower intensity treatments and high intensity chemotherapy, and the overall composite complete response rate was seen in 48% of patients with quizartinib versus like 26% on the control arm. So I think that this is also exciting data coming out.
Definitely. Now, there are also first-in-human results with a CD33 targeted by antibody construct in relapsed refractory patients. So what is exactly the mechanism of action of this drug, and what do we know thus far about the results?
So this is in the category of immunotherapy. So as we know that bispecific antibodies, or BiTEs we call them, are big in ALL. So acute lymphoblastic leukemia has an approved BiTE, which is blinatumomab, and a similar concept is being now used in AML. So they have a unique mechanism of action in the sense that the drug is an antibody that basically binds CD33 positive cells, which is basically over 99% of AML, and also the body's native T cells via the CD3 receptor, and the idea being that you harness cell kill by bringing these two cells together, and so that the T cells destroy the leukemia cells. So this is a interesting mechanism of action, already proven to be effective in ALL and now being explored in AML. And we saw the first in human results. There were 35 patients treated. And we see a cytokine release syndrome, what is expected out of these kind of drugs, but easily treated with steroids and tocilizumab. And interestingly, there were 2 complete remissions seen so far, and 2 incomplete remissions seen. So I think with more cohorts and higher doses, it would be important to see how many patients can go into remission, and more importantly, sustain those complete remissions.
It sounds very interesting.
Yep.
Great. Now, are there any other abstracts this year in either AML or even myelodysplastic syndromes that you would like to mention?
The big one is luspatercept in MDS. So, with AML having a record number of drug approvals, MDS should not hopefully be left behind. So we saw data on the phase 3 study of luspatercept, which is in the family of drugs that counteract TGF-beta ligands. And the idea of the drug is that it improves transfusions in lower risk MDS. So we saw that patients that were lower risk, like low, very low, and intermediate risk, when they were given luspatercept, about 40% of patients achieved transfusion independence and maintained it for a year, which in the lower risk category, we really don't have a lot of drugs to improve transfusions. Once the erythropoietin stimulating agents stop working, there's really nothing to use. So I think that this is an exciting drug, and hopefully we'll see some good news going forward.
Yes. Now, where do you see research going next in AML, and with the number of drugs that are quickly becoming more and more available, is this also affecting any kind of sequencing decisions or considerations that you have?
So I think from a sequencing standpoint, most big centers are already sequencing patients with AML, and I think that should be the standard of care. There's a lot of targeted treatments coming up, so I think that there's a standard set of sequencing data that we're getting on all of these patients. I think it'll be more and more important to get them soon, because you have several of these inhibitors out there, and until you get the full panel back, you really don't know what you want to use. So I think the faster getting these tests faster would be very, very helpful. And from a standpoint of future of where this is going, we are in a very unique situation where we have several drugs that are approved. So what would be interesting going forward is how can we combine them in the best possible way so that we can improve overall survival. And if any of these agents are better at achieving deeper responses and less of measurable residual disease, I think that's what we have to look forward to.
Absolutely.
Yeah.
Dr. Desai, thank you so much for sitting down with us today.
My
You
pleasure.
gave some great insight. We really appreciate it.
Thank you.
Thanks.